Dr. Saurabh Gupta, please. He'll be talking about the femoral closure devices, overview of the devices.
So I guess we had a strong case to make for why you should go radial, and I agree with it. But if you need to go femoral, I think it is worthwhile to understand what the options are and what the devices are. These are my disclosures. So the first step in all closure and access devices is to make sure that you're very familiar with the anatomy. As you know, the femoral artery and the vein lie parallel to each other in the femoral triangle, and then the layers of fascia pass out of the pelvis and form the pelvic sheath. If you look at the relationship in a cross-section, you could see that the artery, vein, and then lymphatics and nerve bundle run in this parallel line. Obviously, the hallmark of all femoral access devices is that it start off with a good stick. And typically in our practice, we'll do an angiogram. Not all devices are feasible in all types of anatomies, and not all of them are approved for all types of anatomies, but I'll go over those and tell you some specifics. Now, what is important to recognize in femoral access is that even in an AP projection, even though the vessel runs, it looks like the vessel runs straight off, when you actually do a 3D reconstruction on a CT, you can make out that the vessel courses posteriorly, and that's where the risk for the retroperitoneal hematomas, etc., comes off. And there's not a lot of convincing evidence that vascular closure devices in general for 6, 7 French sheets, perhaps 8 French sheets, they translate to better outcomes. But I think they're important skill sets to have, especially as you start dealing with bigger sheets, such as those used for transcatheter valvular procedures, TAVR, etc. This is a list of the devices that are available in the U.S., that are approved in the U.S. Not all of them are on the market, and some of them have fallen by the wayside. So the market is full of players which would get introduced, and then after a few months phase out. And the reason for that is this: that in my mind, there really has not been conclusive evidence that vascular devices will actually prevent complications. There's some retrospective reviews. There is some small series, and I'll show those to you just for sake of completeness. So this, for example, is one from 2001, early on in the GP2B3A inhibitors, which were the standard therapy, or coming into vogue as standard therapy for PCIs. And in this retrospective series, at least, people who received a vascular closure device had a 57% reduction in vascular complications when compared to manual compression. Similarly, here's another meta-analysis of 30 studies, recognized that none of these had primary endpoints as being specified for vascular closure devices, but the same sort of trend, that in diagnostic procedures, they were about the same. The only advantage is a faster time to ambulation, and in PCI, perhaps a slight decrease. Certainly no increased risk, right? Because theoretically there is that risk that you would lead to infection, you'd lead to distal vessel closure and vessel disruption because of the vascular closure devices. If you look at the complication rates with the vascular closure device, I'm sorry, this is hard to read. You can see that a lot of those devices, that compares collagen plugs and a suture-mediated device, and then the third one is manual compression, and it shows a nice curve. So I think that both collagen-type devices such as AngioSeal and then suture-mediated devices such as Perclose are about the same. And let's skip that in interest of time. So the general 3 devices that I'll focus on are Perclose, StarClose, and AngioSeal. Just by a show of hands, how many people routinely use closure devices here? Nobody, right? The AngioSeal is an interesting idea. It is a collagen plug which has an anchor which gets into the arteriotomy And then once that anchor, you can see that on the inner portion of the vessel is deployed, you can use that as a rail to tamp down the collagen plug on the top. And then the suture holds both of them in place to form a secure seal. Now, all components are completely absorbed in 60 to 90 days. In fact, the construction of these is made of a PGA, PLLA polymer, similar to the bioabsorbable scaffolds, obviously in different concentrations. And it provides both a primary mechanical as well as a secondary biochemical hemostasis based on the first part being based on the anchor and then the second part being on the collagen. This is how the device looks like. There is a finder locator port, and once you have located the artery, through that, that is obviously exchanged over a guide wire, and through that the collagen plug is advanced. Once your foot pedal and your anchor is in place, the collagen plug is actually damped down in place. It's a very simple device to use. It is very teachable. I would say that to be proficient in it takes about 5-6 devices. We could teach it to fellows pretty easily. The downside is that you're leaving something behind, and at least in people with peripheral vascular disease, that's always a theoretical concern on whether you'd cause more thrombus. The second anecdotal problem that I've had with this device is that there's a small but real risk of late failure. So 24-48 hours out, the typical scenario will be the patient is lifting something and they'll hear a pop and suddenly their artery will start bleeding. Uncommon, but something to be aware of. Now, Star Close is an interesting idea. It is a nitinol-based device. It's a nitinol clip, and the theoretical advantage of that is that you're not leaving anything intravascular compared to AngioSeal, which is the collagen plug is left behind. And the concept is similar, wherein you locate where the arteriotomy is just by the way of a finder sheath, and then once you're happy with the location, you advance your clip, and advancing the clip on top of the vessel, have it snug down. You can see there that the clip is on that bottom panel, and you can advance it. The advantages of Star Close is that you can use it pretty much anywhere in the vessel, irrespective of peripheral vascular disease, or whether your stick is in the bifurcation or is in the SFA, compared to AngioSeal, which can't be used in those locations. The downside, in my experience, is that this device is not quite the same level of predictability as AngioSeal or PerClose. It'll work 95% of the time, 96% of the time, but the 4 or 5% of the time, you really want it to work, and that's when you're holding pressure for 2 hours. So I actually call it the Star Hold device. Or the other joke with Star Close is that a box of 5 comes free with a fem stop. Something to be aware of. It has its own little niche, but overall the predictability is a little bit less. Now, PerClose is a suture-mediated device. There's a couple of varieties of this. There's a ProStar, which is meant for bigger sheath, and then a PerClose ProGlide, which was actually developed by a cardiologist in California before he sold it to Abbott. And it's a pretty neat device. It has pre-tied sutures that you can tie the knot down. So you advance this black soft tip and the arterial locator, which is a metallic portion there that you see. Once you localize where the artery is, you deploy a foot pedal to make sure you have negative pressure. And then these 2 sutures come on either side of the foot pedal, and they're pre-tied. So once the sutures are deployed, you can pull the device out and use that little quick cut button, and this typically gives you a very nice knot similar to a surgical knot. So this is similar to what a surgeon would put in place. The device itself works on about 6, 7, perhaps 8 French systems. Now, the challenge with a lot of these devices is that in that scenario, and especially with a big emphasis moving towards the radial artery, I think that the role there is limited. However, if you look at the newer TAVR population, where we have really big sheets, the device sizes are 24, 28 French. that is a problem, because unless you do a cut down, how do you close those holes? So we're very meticulous with the access there. As you know, successful closure begins with ideal access, and I'll just take you through what our usual routine is in these cases. So we would get access on the contralateral side with an arterial and venous access, and then advance a wire into the contralateral side. And the reason is that for TAVRs, you want to be very precise. You want to make sure that your stick is exactly where you want it, that it's in the CFA rather than in profunda or in the SFA. And then once you're happy there, you would access, hoping to point for the middle of that vessel. And once you've done that, you actually can use a few per-close devices. So you deploy the first device in a 10 and a 4 position such that you get sutures going this way. And then you can take it out, put your wire access back in without tying the sutures down, and then do another one in an opposite direction. And that generally gets you up to about 15, 16, 17 French without any problems. If need be, you can deploy a third device as well, and that is fairly standard for our technique. So I'll move forward with these slides, and those of you who are interested in this technique can just grab me, and I can show it to you in detail on how we do that. So in this particular patient, once we had 3 devices, we were able to easily go through put this long, big sheath. This is a 28 French sheath for the transcatheter valve, and the valve procedure actually is reasonably straightforward. You could go retrograde, deploy the transcatheter valve, and once you're done and the valve is deployed, the sheath comes out and those sutures are tied. And since you have contralateral access, you actually have the ability to tamponade the artery and put in a couple of more per-close devices. Some people have used even 4 or 5. In terms of managing complications after these types of closures, obviously, as you know, vascular device closures are associated with complications. This patient, for example, had some contrast extravasation from the access site, and just responded to a balloon tamponade.
Saurabh, time's
up. Okay, so I think I will stop here. Happy to take questions.